So let's review. I mean, we did this in the early, I think this might have been lecture 2, right, when we were looking at cardiac physiology. But here's a cartoon of the heart with the main vessels coming off the coronary or the aortic root. This is the aorta, ascending aorta, and this is the aortic root. One vessel comes out here and wraps around the back of the heart, and that's called the right coronary artery. Another vessel comes out on the opposite side. It's called the left main coronary artery, and it splits into two. It splits into the left anterior descending, which goes down the front of the heart, close to your chest, and the circumflex artery, which runs around the back, much the same way as the right coronary artery did, but on the other side of the heart. And so that those vessels then descend down towards the apex, and they drop perpendicular vessels into the myocardium to perfuse that muscle. And I think about 5% of your cardiac output goes to your heart muscle to keep it pumping. You know, you pump once a second for your whole life. So that's for an average age person, I think it's 1 billion times for over the course of your life, right? So that's if you look at inside one of these vessels and the diameter of these things when they first come off the aorta, they're, you know, on the order of 3 to 5 millimeters in diameter. And so it's a fairly chunky vessel. So here we zoom in to take a look at one of these large vessels coming off the aorta. And so from here to here could be 3 to 5 millimeters. And then inside this vessel, you see there's this buildup of fibrous tissue, calcium, and sometimes a lipid that's in a little spot. Um, and what it does is it decreases the caliber of the vessel. So we started out, say, with a 5 millimeter caliber vessel. We now have a 1 millimeter caliber hole that the blood can go through. And so we've dropped that, you know, by 80%. And so that's a reasonably significant stenosis. Usually anything that drops the caliber of the vessel below 70 to 75% is called a severe stenosis. If we look at this vessel, we can see that there's just a very thin wisp of a channel left in that vessel. And so that's usually called a 95% stenosis. It's not truly 95. They're all just called 95 to label them as like a wispy little bit of a vessel that's left open. And so blood can get across. When you do an angiogram, you'll see there'll be a big dark spot here, but there will be blood on the distal side. And I think I might have an angiogram here. Yeah, here we go. Here's a vessel that goes down to this tiny little, uh, line right there. So that's a 95% stenosis, but the blood does get through to the distal side and come down, right? So that's not a complete or a total occlusion of the vessel, which is this case in the middle, in which the lesion itself has just closed off the vessel entirely. And so when we look at it on X-ray angiography, we'll just see a stump. Basically, it just ends and no blood goes down on this part. There are devices that you can put on a guide wire and bring up to a lesion like this and basically drill through this lesion to open a channel to get to the other side. And that's called reopening a complete occlusion. It is an active area of research for people in medtech to try and figure out how to do that with a device that doesn't cause, say, a rupture of the vessel. We need to know which way to drive the device through. But if on X-ray you don't have any imaging down here because there's no contrast getting down there, it's an educated guess as to which way you push that thing through. Similarly, we're going to push a device across this stenosis in order to essentially place or position a stent such that we can blow up the vessel and open it up. The cascade of events for people that are suffering from coronary ischemia or coronary disease is the following. This is, totally schematic. Here we have signs of ischemia. Myocardial perfusion is on this axis. And so as the myocardial perfusion is reduced in some piece of muscle because the upstream vessel has a narrow caliber, and as that caliber goes down much lower, or the demand for blood goes higher because of exercise or stress, we'll see the myocardial perfusion or relative perfusion go down. And then, so here are the cascade of events that leads to a critical situation or a heart attack, where you first have hyperperfusion, and the first thing that changes in the tissue are metabolic alterations because you don't have enough oxygen. And so the tissue will change its metabolic behavior principally because you don't have the oxygen to feed certain reactions, right? And it will cause um, uh, molecules that are required for contraction. It'll stop expressing those or making those molecules, and the contraction will, and the depolarization from the electrical function will change. So we get first metabolic, and then oftentimes the first sign as the ischemia gets worse that you have a chunk of tissue that's suffering from ischemia is that diastolic function will look abnormal. And what diastolic function is that we start with a chamber that has, 250 mils of blood or 200 mils of blood. It contracts down to, say, 75 mils of blood. And then diastolic function is how the heart opens back up and fills. And that motion is usually a fairly rapid motion. It contracts over the course of about 200, 250 milliseconds, and then it will pop back open over about 50 milliseconds. That popping open is one of the first things, an abnormal way that the heart has diastolic function or filling is often an early sign of ischemia. And most of the time, it's the heart opens slowly, as opposed to popping open. It'll just kind of open in a slower form. After that, you can see as the ischemia gets worse, the ability of the heart muscle to contract at all can go down. And we saw this with stress echocardiography. This is principally what you're looking for in stress echocardiography, is you watch the heart contracting and then you see, oh, one of the walls just stopped contracting. So I have two walls contracting like this, and then one just stops. And so I know that this one has the ischemia, right? And so that will happen at a certain amount of perfusion drop. Then we'll see ECG changes, and we'll study those a little bit in the next few slides. And if you're lucky, those ECG changes show up, as indisputable evidence that you've got some kind of myocardial perfusion deficit. And there are classic signs on the EKG. Sometimes those changes don't happen. And so the patient is left without the advantage of that diagnostic test being positive. And then after that, usually you will suffer pain. And the classic pain, and you can see this in public service announcements and stuff like that, is the classic pain is a pain in your jaw, lower jaw, that radiates down your arm, right? Which sounds strange because this is coming from your heart, right? But the pain profile is that you get radiating pain into one arm. And if you get that pain and people are, tell you classically that's what they're feeling, then that indicates there's a high probability that they're having actually an acute heart attack, right? Again, lucky people have that pain occur up here, like at higher perfusion, earlier on in the cascade of events versus the perfusion almost gone, and then they have the pain, right? You want the pain early, actually, so you go, well, something's wrong here, you know. And I've seen people, we've scanned them where they obviously have an infarct, and you ask them, have you had a heart attack previously? And they had no idea that they'd had a heart attack. Sometimes they'll report, oh, I felt kind of nauseous, didn't feel great, just walked it off, and that was a year ago, right? Uh, and because the pain wasn't bad, they just didn't go to the hospital, right? Again, I've told you this statistic previously, but in something like 50% of the people, the first physical sign that you have significant heart disease is you're dead. Okay, because this comes on quickly. The heart goes into a very bad electrical arrhythmia and stops, producing pressure and blood, and you fall down and you die, right? And so that's called sudden death, and it's not uncommon, right? And I had a very good colleague die in the lab next to me. He just fell out of his chair and we couldn't resuscitate him, right? So the this whole thing can happen very quickly and it can disguise itself. Humans are really good at adapting such that they, can ignore physical problems. The lowest resolution form of imaging is the ECG. And basically what you're doing is you're mapping voltage differences on the surface of the patient as a function of time. And those voltage differences on the surface repeat, they're reproducible, and they go with the heartbeat. Because there is an electrical field gradient across the heart as it depolarizes and repolarizes, that gets mapped up to the surface, and you can put leads on the surface and measure the picture or samples of the picture of the voltage map on your body. And the classic three leads, the first one is the voltage difference between your right arm and your left arm, and that's called lead one. And the voltage difference between your left leg and your right arm is lead two. And then the voltage difference between your left leg and your left arm is lead three. And some imaging devices will have only three lead patches on. And then what's displayed on the console of the imaging device is lead one, lead two, and lead three, and you see each waveform. And normally you don't really care about the details of the waveform for imaging, other than you want the scanner to trigger at the right moment and a reproducible trigger. And so that's usually the QRS pulse, which we'll see. And so you just look at all of those leads and say, which one has the best signal to noise for capturing the QRS, right? And that's used in nuclear medicine, MRI, CT. The ECG is usually always taken during the imaging. There's three other leads that are mathematically created. It's the right arm minus the mean of all the leads, the left leg minus the mean of all the leads, and the left arm minus the mean of all the leads. And so if you're doing a 12 lead EKG, you put 6 more leads on the patient and they go across their chest and around their back. You can see it's on one side of the sternum for V1, just on the other side for V2, and then these extra 4 go around the back. So that gives you voltage differences across, the chest right above the heart, which is terrific. And those 12 signals are displayed on a sheet that looks like this. So there's 1, 2, and 3, the AVR, AVL, and AVF down here, and then these are the 6 chest leads over here. And so when you look at this data, this isn't an image, or you could think of it as a 12-pixel image in which each pixel changes its color as a function of time, right? That's another way. You could train somebody to read that, probably a 12-pixel image that changed color as a function of time. But they've been doing it like this for 100 years. So a cardiologist will look at this 12-lead EKG and become remarkably good at figuring out or recognizing pathology right away, just looking at that. As you can imagine, each one of these is, I don't know, you're probably taking 1,000 points a second or something for 2 seconds, so 2,000 points here. So we've only got 24,000 data points on this sheet, right? and they're highly correlated so that you could bring that down. So bottom line is you could teach a network to read this thing, right? If you have 2 million of these and you know what the various disease categories are, there you could in an afternoon teach AI to read this. So I think only in very subtle disease states that are unusual, that are way outside a training set, would a human being come in and say, given this set of voltages, the morphology of the underlying ischemia or disease is, I'm going to guess, is the following. And humans might beat AI on that, but for standard stuff, I'm sure they don't. I'm sure it's probably all read by AI by now. So a normal QRS looks like this. So for each one of those pixels, the 12 pixels, the time domain looks like this. The voltage goes up when the left atrium contracts. That's called the P wave. So you get a little voltage pulse for the atrium. And then there's a delay while the excitation goes from the atria down into the ventricle. And then the ventricle contracts, causing a very large spike in voltage because it's a big muscle mass and it's a large thing in your chest. And that's all the QRS complex. And normally this is where you trigger to essentially make your data acquisition coherent with the heart rate. You trigger on the QRS because it's usually the highest voltage and it's not susceptible to signal to noise problems of false triggers. And then after the QRS, there's a quiet phase after the heart's contracted. And then the T wave is the voltage that is mapped out when the heart repolarizes or diastolic filling occurs during that repolarization. The main thing that you're looking for people who have myocardial ischemia that is affecting their myocardium is called ST elevation. And so what happens is the voltage between the QRS and the T wave in this ST segment never really gets back down to baseline. Okay, and that's called ST elevation. You can have ST depression too. ST elevation is classic. And when a patient presents with this ECG on any one of their leads, you basically send them to the cath lab, right? Whatever time of night, you just get people scrambling and they go to the cath lab and they put in a stent to try and stop this occurrence, this myocardial ischemia. And this is called an ST elevation myocardial infarction. It's called a STEMI. And so that's an emergency procedure that they'll do whatever time of day, get you into the cath lab. And so here's an example of a STEMI, and you can see on the QRS for the lead 1, lead 2, and lead 3, everything looks pretty copacetic. I mean, it looks pretty normal, right? These leads as well, nothing looks crazy over here, but when we get to, V1, V2, and V3, which are these leads right across the top of the heart, you can see there's a big QRS complex, and then this voltage never comes back down to 0 before the T wave. So this is classic ST elevation right here, and that person goes straight to the cath lab. And then when they get in the cath lab, you see something like this, right? Which is this really tight stenosis, obviously causing a large reduction in flow in the tissue perfused with this part of the vessel and this part. The contrast is getting through that tight stenosis to illuminate, those vessels, but the flow must be very low because it's causing this STEMI, right? Just as a reminder of what type of image this is a real-time X-ray image that is a one-dimensional image. The patient's on a table, have a source above the patient, a detector below, shine, get a dynamic shadow. And before taking that image, what we do is we take a catheter, put it basically in their groin, in an artery in their groin and in the femoral artery, and it comes up their aorta, loops around, and the plastic thing goes down into the root of the aorta, gets engaged with the coronary, and you inject a dye as you're taking the picture. Okay, so it's in real time. And you see this probably, if we saw a movie, this would fill slowly, right? Because it's coming through this tiny little gap here. Right? So that's a STEMI. And this low resolution 12 pixel image is enough to detect that, right? So we don't really have high resolution there. You've just got ECG. So what do you do once you've got that patient? So you're sitting with this patient here. This tissue is probably still viable down here, but you really want to open up the flow for this poor guy. So if the vessel has a really tight stenosis, and here's the caliber of the vessel, and here's the stenosis, this guide wire goes through that same catheter. You push the guide wire out into the vessel, and you push the guide wire across the narrowing. And using little X-ray markers that are on either end of this balloon that is right here, you center up the balloon such that it's centered on where the stenosis is the most severe. And then we can pump a fluid into this balloon, which is collapsed right now, and this metallic scaffolding is collapsed around the balloon. So then we fill the balloon up with fluid at a certain pressure, right? You don't want to overpressurize it, but you set it to a certain pressure and it expands the stent, which now the scaffold opens up and it creates a much wider vessel here. And so then we let this balloon down and the stent remains in this configuration. Okay, so it remains open and keeps the vessel open. So it looks something like this. And then ideally, what's going to happen is that the vessel will endothelialize around that stent. So it'll put inner vessel wall cells around the stent. So the stent will eventually be buried in a new coronary artery wall. That would be the ideal thing, right? In the early days of this therapy, the stents were just bare metal, stainless steel stents, and they used to cause thrombosis because there's a foreign body inside the vessel. And so blood, sort of flowing by the stainless steel would get caught, you'd get a thrombolytic reaction, and then you'd have thrombus downstream. What they do now is they bathe this material in a drug-eluting coating. And so the coating essentially dissolves over the course of weeks, and in the coating is a drug that stops thrombus. It doesn't let thrombus form. And so those are called drug-eluting stents, and that's essentially all the stents I think that you would see these days for this purpose. The other interesting thing is when you're going to let this balloon down, right? As soon as you let it down, the blood flow is going to go back to almost normal. And the tissue downstream has not seen normal blood flow in some time, right? So it's an abnormal, it's a shock for the tissue downstream that all of a sudden it's being highly perfused, with this blood. So normally before bringing this balloon back down, you would inject a drug distal to the balloon, so down into the tissue that is beyond the balloon, and it's a drug that will tamp down electrical excitation of the tissue. It will numb the tissue a little bit so that when we open the vessel, it doesn't, boom, go into some crazy arrhythmia. Oftentimes when you do open that vessel, if the patient goes into VTAC or some kind of ventricular arrhythmia, you need to then deal with that. So you have to shock them or do whatever to try and get them out of that. But it's a tremendously successful procedure. So many, many people have their lives saved and chunks of their heart saved by showing up at the hospital in time to have a stent put in and reperfuse the tissue before it dies. Okay. And so in 2010, like over 2 million procedures are done. I don't know what it is in 26, but it's probably 4 or something like that. And highly successful technology in order to save people's lives who are having heart attacks. Here's what a bad vessel looks like. If we get the patient on the angiogram and we look at this vessel here, and it's called a ratty vessel. It's just a mess. There's lots of different widths of the chain of the vessel diameter. But this is probably the culprit lesion that is causing an ECG abnormality, and this is why the patient is here. So you drop a stent in there, and it looks like this. It looks like this patient also got some stenting done up here. It looks like they left this one alone here. Yeah, so it's mostly this. You can see the stent starts here and goes to about here because it's darker. So we've changed this situation where I had this tiny little hole to this situation where I have a nice big vessel. It sure seems to me that that's a better situation, right? To be here. And in patients who have STEMIs, patients who have ECG abnormalities and come into the hospital, definitely getting this done dramatically increases the probability that you will survive for the next 10 years. Okay, your survival goes up. What is interesting, though, is if this does not cause ECG abnormalities or pain, and you seem to be living okay with this low-grade ischemia, then putting a stent in because you could make the argument, look, you're going to wind up coming back to the hospital as an emergency patient with this lesion here. Why don't we just put a stent in now? Let's do it. We'll get that done with. So you put the stent in, or you don't, or you just give the patient the optimal drug therapy. And so there's been two very large trials in which they took patients who have stable ischemia or stable coronary heart disease, because you can see it, it's there. And then in one trial called ischemia, they only took patients who had positive SPECT. So we'll get to that, like we're still on SPECT, right? So there's a perfusion abnormality in their heart, and it's confirmed. So we take those patients, and now we flip a coin. In one half, if they get heads, they get a stent. If they get tails, they get the best drugs. Okay. And it's an interesting trial, right? Because you think, who wants to be in the tails section? I don't want just to put the stent in. That's sort of my emotional response. But to do something like this, you need to do a random trial. And actually, when people are looking at the data, they should be blinded to which arm the patient's in. So what do you think happened? The patients who had ischemia and had a stent versus the patients who had ischemia, and they just gave them the best drugs they could. Who died the most of those groups? The ones with drugs, you would think they're going to perish the most because they're not going to make it back to the hospital, et cetera, right? They're going to die before they get back to the hospital to get the stent. Everybody thought that's what was going to happen. And two trials went through, and that did not happen. It was 50-50. It was just equal risk, right? We're not talking about patients who show up at the hospital with chest pain and EKG abnormality. Definitely you get a stent in that situation. We're talking about people who, when you image them, have disease. But then if you treat the disease with drugs or with a stent, it doesn't seem to matter. So basically, as long as you're on those good drugs, you have equal probability of surviving, which is kind of interesting, right? And so the people who ran those trials were usually people who were interventional cardiologists, people putting in stents. And they wanted to just show the obvious that's going to be true, is that of course it helps to put stents in. And in both trials, it did not. So very interesting. That's called the ischemia trial. And I think I have, on the problem set, I think there's a question about the ischemia trial. So you read a bit of the paper and figure out like what went on. A really fascinating thing about the ischemia trial was when you looked at the nuclear medicine data and you tried to predict, just based on the perfusion data, who survived more than the others. So people with severe ischemia, like a big positive nuclear medicine versus grade 1, not so bad ischemia on nuclear medicine. Ones with really bad ischemia versus those with not so bad ischemia. Which one of those groups dies more frequently? For me, for my money, I would have put a lot of money on the bad ischemia patient. They're close to the edge, right? Okay. You say, yeah, you're going to be the first to go. Nope. These guys were the first to go. And the reason, more than likely, is because when you have bad ischemia that is not critical, that has not caused ECG abnormalities and pain and all that, you're basically training your heart to survive on low blood flow. And so you can have small additional events, ischemic events, and your heart's conditioned to survive that event. It's like an evolutionary process, right? So the people with bad ischemia that have survived to them, they're tougher. It's going to take more to kill them, right? Than the people who have been tried less. It's fascinating result, right? And this is shown in labs as well. It was shown a long time ago that if you precondition before doing a profound perfusion closure. So let's say you can do this in an animal model like a pig. You blow up a balloon and you make the tissue ischemic for 10 minutes and then you let the balloon down, perfuse it. Blow it up again, 10 minutes, let the balloon down, perfuse it, right? You do that 3 or 4 times and then you blow up the balloon and leave it up. So now we've got a profound heart attack that's going to happen here, right? If you do that to tissue that hasn't had the training, that you just do that first, blow it up, hold it, the mortality rate is like 68% or something like that. But for those hearts and tissue that you've trained with these 10-minute occlusions, when you blow it up, 25% mortality rate. So it's like it learned very quickly how to cope with low flow. And so you get these results that are kind of unexpected. So what does low myocardial perfusion look like on nuclear medicine? We saw a couple of examples, but here's a patient who had both a CT with an injection of a contrast agent and a SPECT scan. And so we're looking at the same view of their heart on the CT and the SPECT. In the CT exam, these images look really good because, one, the perfusion deficit is very high. Two, the dose of the CT is probably very high. They probably use a lot of photons. Three, they probably injected a lot of contrast into this heart. Okay, so when you do those 3 things, you can get CT perfusion pictures that look like this. You have normal myocardium here. This is the blood chamber. And then this section here just doesn't enhance at all. No contrast seems to have got there, so that's really low flow. If we cut this way and look at the donut, we see how much angle is taken out by this thing here, and it shows here. And then if we cut it down this way, look at another long axis, you can see there's the 3D of this thing is a really big flow deficit, right? So there's some major vessel upstream from this volume that has just been shut off, right? No flow is getting down here. So look at the difference between the SPECT and the CT in terms of spatial resolution. I mean, the SPECT looks like a big fuzzy blurrogram, right? And that's because, as we saw with the detector, though, they're really big elements, and this is taken over many minutes, right? It's taken over 20 minutes or something. And so we see there is a deficit, same as this one. On the short axis, we see a deficit. Again, it's a profound deficit, and here there's a profound deficit. Okay, so for this patient, a nuclear medicine scan was a useful thing to do because you're showing, oh my goodness, there's profound ischemia in this patient. This is the type of patient that then would be admitted to the ischemia trial, right? As to whether or not to give him drugs or a stent. So we looked at this briefly. This is the stress imaging and how you do it in SPECT and the effect of the attenuation correction. And so normally on every SPECT scanner now, this made them more expensive, but it's well worth it. You have a CT scanner that's attached to the SPECT scanner. So essentially, before you put that detector on to look at the patient, you put them through a small CT scanner on the same table, and you make a low dose CT image to do attenuation correction, as we discussed last lecture. So here's a patient in which we have stress, right, and rest. And let's look on this side. These are the short axis images, they're called. So they're the various donuts as we go from the base or the valve plane down towards the apex of the heart, right? And what we can do with these, this display is called a bullseye plot. And just like a target bullseye, in the center of the target is the apex of the heart. So if I draw my cursor around here, I'm going around a short axis slice that is towards the apex. If I take my cursor and I go out here, draw it around, that is a mid-level short axis slice. So it's halfway between the apex and the base. And then if I draw along here, that's the base of the heart. Okay, so the display you can think of, if the heart was shaped like a bullet, with the bullet looking at you, we're looking straight towards the bullet, and this is the apex and this is the base. That's called the bullseye view. And the great thing about it is you can get the whole heart on one flat 2D image to make your call. So in this patient, with this CT attenuation correction on board, we have a rest image that looks like this and a stress image that looks like this. And so you would say, there's a lower amount of activity in the myocardium all the way from just above the apex up towards almost the whole base, in which we have this low activity. In 3D, it looks something like this. And that's after we've stressed the patient. So they've been on a treadmill, or we gave them a drug to increase the demand or the perfusion through the coronary arteries. When we shut off the stress and then we go back and do another acquisition when they're just resting, this abnormality resolves. It just goes away, right? And so this is a positive stress test in which the tissue resolves post-stress. And so this tissue is probably alive, right? It's not an infarct. And it has a low level of perfusion, more than likely, right? Now, as we said yesterday, or on Monday, I'm sorry, this is what happens if you don't do that CT attenuation correction. You get profound block of activity signal because it's deep within the chest on the posterior wall of the heart. And you lose the ability to resolve whether or not the stress and rest are different, right? So you really want to do that attenuation correction. Recall, again, we've seen this slide before, the two main vessels. This is the right coronary artery. This is the left main, and then the circumflex is here, and the LAD is down here coming down the front of the heart. And these are the regions that are perfused by those different vessels. And that's why we look at our results in this bullseye plot or in these plots here and in the long axis. We can see which vessels are more likely to be causing the perfusion abnormality. We'll look at this with PET mostly, because with PET, because we can acquire the data fast enough, you can, when you inject the contrast agent, you can see the input function. So if you look at the signal in the left ventricle, you will see the brightness go up and then back down as the contrast goes in. And if you have that input function, you can actually solve for the absolute blood flow in the myocardial signal, which will be in milliliters per minute per gram, or milliliters per minute per milliliter of tissue, right? And here's an example of again, a bullseye. This is, remember, the base of the heart is here, mid and apex. The lateral wall is, remember, we're looking from the patient's feet towards their head. So over here is the patient's left arm. Here's the patient's right arm. This is their chest, and this is their back. Okay. And so we get these numbers here, which is the myocardial blood flow at rest. And this is usually done with PET. Sometimes you can do it with these newer SPECT scanners that have the CZT detector, such that you can grab your data quickly enough to get an input function, but it's nowhere near as good as PET or MRI perfusion. But here where you can look at the blood flow during stress, and you can see the blood flow here went up to 2, 2.8, 2.68. So we get much higher blood flow over here. Here, the blood flow basically went down. Okay, it went from 1.06 to 0.73. So this chunk over here seems to be suffering in that the flow rate is not going up as high as the other areas in the heart, and in this case, it even dropped. Okay. However, you can see it's a bit noisy, right? So we've got 3.4 over here, 1.6 right next to it. So, like, what the heck is actually happening? I think PET is, you can have confidence in the perfusion results from PET. From SPECT, I'm not so sure you want to go down that pathway. So if you say, well, if you can't figure out the blood flow, why are you doing this at all? It's because in this picture, I don't really care what the actual value is here. I just care that this value is higher than this value. So there's an abnormality because I don't know what the blood flow is here, but I do know it's lower than what it is over here. Okay, so it's all relative. And you look at it with this relative map. So how do you stress the patient? So here are 5 different methods for stressing somebody when you're doing nuclear medicine. And the first and easiest one, well, I don't know if it's easiest, but is they're sitting in the scanner, or the scanner is an upright scanner, but most of the time they're lying down in the scanner, and you have a bicycle that's on the patient table, and they push the pedals to get their heart rate up, right? And it's basically, you get coronary vasodilation in the sense that as the blood flow demand goes up, your heart beats faster, and the signaling is, look, I need to open up my vessels because my cardiac muscle is beating faster. And the problem is sometimes you can induce tachyarrhythmia, which means the ECG gets abnormal. You could go into ventricular tachycardia, for instance, where your ventricle starts beating very quickly and it decouples from the atrium. You can get atrial tachycardia, hypotension. So if the patient isn't very fit, the exercise can cause a sudden drop in blood pressure. And for many patients, they're sick to begin with, right? And they could be very old. And so exercise just isn't something that comes easily, right? And so they're unable to actually do it. Not only that, if you pump the pedals of a bike, if you're good at doing it, you're going to have to breathe deeply, right? So your breathing goes way up. And so the motion from breathing goes up because the patient is panting or breathing deeply, right? So you say, hey, hold your breath for a second, and they're not going to be able to hold their breath for that long because they're pumping this darn bicycle. Whereas all of these drugs basically get the same thing done in that, well, these 3 especially, you open up the vessels, and so the demand goes up, but they're not breathing heavily because they're not doing exercise, right? It's essentially a hormonal thing. You're activating these receptors that normally activate with like adrenaline, right? Or adenosine is is essentially a receptor you make. And when you need to dilate your vessels, it's used as a signaling molecule to open up various receptors, and then downstream activity happens. Essentially the blood vessels relax and open up, right? So adenosine is a natural contrast agent. It's been used for a long time. Has a half-life of 10 seconds, which is great because you can essentially administer the adenosine to get the effect, but then when you stop the adenosine, very quickly the effect goes away, right? And why would that be important? Remember, the person that you're imaging is a cardiac patient, and so they're there because they're close to having a heart attack. And you're saying, I'm going to stress you such they're even closer to having a heart attack, or God forbid, having a heart attack on the table. So if you're giving them adenosine, and then their symptoms go way up in terms of they get EKG abnormalities, they get pain, then you stop the adenosine, right? And essentially when you stop it, 10 seconds later, it's gone. So that's a good thing. Dipyridamol, on the other hand, it will preferentially open up heart vessels, which is great, right? But it has a very long half-life. So you can't really shut it off just independently. You can shut it off, but it's going to last for another 40 minutes. And so normally you would need some kind of agent that tries and cleans this stuff up. So you would, if you need to shut it off, you would put it in another drug. It makes it more complicated. This is the new kid on the block, basically, reganenosone. And again, it's the selective adenosine receptor. There's 4 different adenosine receptors on your cell of these of the vessels, and this one is an agonist for A2A, and an agonist means it behaves the same way adenosine does when it goes up to this receptor, binds to the receptor and tells the receptor, I'm here. So you get hyperemia for 2 to 5 minutes, so it'll go away pretty fast. I think with any of these, you can get headaches, you can get flushing, stuff like that. So, and some of them actually will cause heart block, which means the electrical signal from the atria as it goes down through the Purkinje system into the ventricles, that transfer of electrical signal gets blocked. And so then the ventricle and the atria are beating kind of independently. Okay. The last one on the list here is dobutamine, and we saw that with echocardiography, and that's done when you want to increase the contractility of the heart, but not necessarily increase the perfusion as much. It's mostly used to increase the contractility. And so the demand for blood flow comes from the fact that the heart is contracting much more vigorously. And this is one in which you inject this agent at different levels. So if I have dobutamine here, I start at 5 micrograms per kilogram of patient mass per minute, and you have a drip on your drug delivery, and you just open up that drip to go 10, then 20, then 40. And then as you go up, the heart contracts more and more vigorously. And then when you shut it off, the effect ends. And so here's the doses used for these other drugs. So terminate, test, and inject tracer, blah, blah, blah. Okay, so we can move on. Okay, so let's look at some SPECT scans from patients in different conditions. Okay, so this is a normal, no mystery. So we have stress here, rest here. I'm assuming we've done our correction. And this is our bullseye function: apex, anterior wall, lateral wall, inferior wall, and septum. We can see they look pretty similar after stress and rest, right? So you could not induce a perfusion abnormality in this patient, and their rest scan looks the same. Interestingly, in this patient, for whatever reason, they had invasive coronary angiography, so you could look at the vessels and see what was there. There was a 30% LAD lesion and a 50% mid-RCA lesion. So when you look at the X-ray, that there was a distinct narrowing of the coronary vessels, major coronary vessels. However, even with that distinct narrowing, it did not affect the rest stress blood flow. So this patient, even though they had positive disease on angiography, this patient would not have been admitted to the ischemia trial, right? Because they didn't have baseline ischemia. So even with those coronaries the way they are, they're doing just fine. Oh, here we'll see you can reconstruct. We might have a movie of this later where you can reconstruct, excuse me, different images at different times. I think I have a movie. Let me see. Yeah, I have a movie of that later. We'll talk about that later. So here's the raw data from which those images are obtained. And you can see this, the device itself has a very large field of view in the Z direction, right? But for us, it's not necessary. We just need this data here. So here, this is an interesting case in which we've taken an ECG while we're obtaining the SPECT imaging data. Okay, so we have counts at a specific angle, and we'll stay at that angle for, let's say, 30 seconds, right? Over that 30 seconds, we'll get 30 heartbeats. Inside those 30 heartbeats, we'll measure where the EKG occurs. By that ST peak, we'll get a trigger. So we'll trigger a marker for the beginning of the heart cycle, and then get the next marker. And we'll say that is a whole heart cycle. All of the data we've acquired over that 1 second, we're going to break it up into 10 buckets. And we'll take 10% intervals of that time, which is the QRS, or the QRS to QRS. And we'll make an image of each bucket. Okay, so we'll only use the activation from 0 to 10% to make one image, 10% to 20%, make another image, 20 to 30, 30 to 40. And so that gives us 10 nuclear medicine pictures. And then when we play those back, they look like this. Okay. And so here's the end diastolic short axis view of that data. And this is the data over the course of one whole heartbeat. And it's pretty interesting, right? In that it's not surprising that when you don't do this, you get very blurry data, for one thing, because all of this data would be averaged together, right? It also gives you an indication of the relative health of the myocardium due to the mechanics of the contraction. So if one half of this heart wasn't contracting at all because it had an infarct, this map here would look quite different, right? There'd be a chunk that just wasn't contracting, right? And here's the long axis view. So remember, this is 3D data. We can cut it in any way we want. So, you know, I think it's one question you have is, this data looks very good. What was the dose of agent that you had to give in order to get this data, right? So each one of these 10% pictures seems to have the same image quality as what we were seeing from the whole heartbeat before. So the question is, did you inject 4 times as much contrast agent in this patient to get it, you know, to scan like this? So there's going to be a trade-off there. But I think doing sensible windowing of where you acquire your data makes a ton of sense. If you wanted to acquire your data basically in only the sections where, or the temporal sections where the heart was full of blood, that's probably 50% of the heart cycle. So you could just use that 50% and then use the other 50% as the dynamic part. So here we have in a patient who had a coronary CT scan, in addition to their their SPECT scan, we see the stress and rest of their SPECT scan, and it doesn't look like in stress there's any abnormality. It looks similar to the rest. Here, it looks similar to the rest. Same. So it doesn't seem you would call this person positive on their nuclear medicine exam. You would say they don't have any perfusion abnormality. When you look at the coronary artery in the CT, it is absolutely obvious that there is a lesion here, right? And that lesion is probably, if I was to call it here, it's, around 50%, something like that, right? So this is the width of the coronary vessel here and here, probably a few millimeters. That little thing there is probably half of that. Round numbers, right? So this on coronary CTA would be called positive. So now we have, there's a positive CTA saying, yep, this person has coronary artery disease, a negative SPECT saying they don't. Is this a false negative? That's the question, right? Is it a false negative, or is it that you are measuring perfusion and they don't have a perfusion abnormality? So there's a tension between these two tests. This test, turns out, is more sensitive. Okay, so if we do the classic sensitivity, right, which was the true positive patients divided by the true positives and false negatives, the total positive group, right? It's a very high sensitivity, right? However, when you get to the cath lab, so you do your CTA and you see this and you call it positive, and this patient goes to the cath lab and they get in there and they look at it and go, yeah, that's a 50% lesion. And then they just take their gear out and go home. They don't put a stent in, right? They don't do a bypass. All they did was another exam. Then you ask the question, well, is the CTA referring too many people to coronary angiography? And in the early days of the development of cardiac CTA, this test here, there was huge pushback from interventional cardiologist physicians who did coronary cath. They said they did not really want this test. And they wouldn't refer people to this test because they feared that the person doing this test would become the gatekeeper to the cath lab. And so you would have to go through this door to get into the cath lab. And insurance companies would say, we'll let you cath the patient as long as you go through this door, right? And then this was 20 years ago. The vision was that, oh, good Lord, these other physicians and the insurance company, everybody, will be in control of who comes into the cath lab. And our business will plummet. And we'll be standing around half of the week with nobody to scan, right? This is a really interesting story. It's like a parable. So people continued to develop this technique. It got better and better and better. And so you got images like this. And when they did do studies where they did the CTA first to determine if you go in the cath lab, what do you think happened? Twice as many people were referred to the cath lab. So now there was a huge line out the door. They had too many people to scan, right? So the exact opposite happened, right? It was because this became highly sensitive to coronary disease. However, when you looked at who went into the cath lab, a lot of those patients, they said, oh yeah, there's disease there, but they didn't do anything. They didn't put a stent in. They didn't do bypass. So all it was another positive exam that did not lead to some kind of treatment. So it was just extra expense. So that's the thing, is like high sensitivity, but what implication does it have for the downstream, treatment of this patient. Perhaps this, even though it has lower sensitivity, maybe the SPECT is a better way to go because you're not going to take this patient to the cath lab, right? So there was a very big trial called PROMISE in which, and I recommend you read the trial. I have a couple of slides on the PROMISE trial where they looked at this image versus this image for determining what to do with patients, downstream. It's a very interesting trial. We'll take a look at some of the results. Excuse me. This is a positive stress test in nuclear medicine, and it's called inducible ischemia. And that is when you stress the patient with any of those agents we looked at, adenosine, dipyridamole, regadenoson, or a bike. When you do the nuclear medicine scan, the activity in certain areas goes way down, okay? Or there's an imbalance. We don't really know what the absolute activity is of this wall here, but we do know that this wall is a lot less. So it does seem that there's ischemia. And here is the stress. It's the apex, inferior septum, inferior wall, and the apex. Okay. What do you think? Which vessel's that? We know which one that is, right? Think about it. You can go back to the slides before and try and figure out which vessel this is going to be. But then we stop the stress and we let the patient recover, and then we do another exam, another nuclear medicine exam, and this comes up. So this resolved in the sense that without the stress, it was getting almost as much perfusion as other sort of normal parts of the myocardium. Okay? And so that's good news in that we know there's some flow there. It's different. There's a gradient, and when you stress it, that gradient really shows up. But at rest, there seems to be a minimum amount of flow, and the tissue is probably still alive, right? So that's what, so stress showed no EKG changes, though the patient did get chest pain during stage 4 of the Bruce protocol, which is a stress agent. Okay, so they did get some pain when they were here, but they didn't have EKG changes. So this is what happens when you are late to the game and the patient has had chest pain, they've fought through the pain and lived to tell the tale. And this happens a lot, but what happened was a coronary vessel either was totally occluded or it was severe enough that the perfusion downstream in the myocardium got so low that the tissue just died. Okay, those cells in a patch of myocardium died. And so now they have this chunk of dead tissue on their heart. The rest of the heart's contracting. But if you looked at it, if you looked at a movie with, say, MR tags on it, there'd be a chunk of tissue that just wasn't contracting. It's just sitting there, right? Then over time, the cells in that chunk of tissue, which is called an infarct, those cells are going to be replaced by fibrous tissue and scar and things like that. And so the wall tends to thin down. It's not perfused as well, and it doesn't contract, right? And it's called a myocardial infarction. People are walking around with myocardial infarctions all over the place, right? So what does it look like in stress test imaging? So when you put the patient in and you stress them, we don't know that what's in there, right? But this comes out and you go, oh my goodness, this is really low flow. Don't even have a signal at all, right? For this apex of this heart. And then we turn the stress off, let them recover, do the rest. And you're like, oh my goodness, it's not even there at rest, right? And so there's a hole in the apex and that hole stays there. That's called a fixed artifact or a fixed abnormality. Doesn't resolve after you take the stress away. And most of the time, virtually all the time, it is an infarction, chunk of dead tissue. Okay. What can happen is that dead tissue gets thinner and thinner, and then it starts to balloon out and expand, and then the heart goes down a failure pathway. There have been attempts to, if you see an infarction like this, could you just cut it out surgically and sew together the other normal sides of the heart, right? Yeah, to prevent the thing from dilating and going off the rails. But then if you go down into extreme myocardial failures such that you can't generate pressure, you can't generate blood flow, then you go on the transplant list and you would wait for a new heart, you know. Oh, we zoomed this up. So there you see what a fixed defect looks like. I think, oh yeah, these are the raw data for the fixed defect. And it, remember we looked at that one there, there's a chunk just missing right out here, right there. So the stress, look at the level of the noise on the stress is higher, right? So they probably took it with less averaging than they did on the rest image. Okay, here's a profound, this is a heart like towards the end of this person's days. And so you can see there's a huge deficit, you know, of blood flow here towards the apex. And when we do this binning of the data, the heart itself, remember that when we looked at before, the whole thing became bright and it contracted down. This one never really makes it to contract down. The ejection fraction in this patient is probably 20%, something like that. And so this person is in profound heart failure and has a number of fixed defects, so a number of infarcts. And here's a look at the ventricle down here, and you can see it's barely contracting. So this person, once your heart ejection fraction goes down below 30% or something like that, and you're not getting better, then they would probably put you on the transplant list. Okay. And here is a mixed ischemia. So this patient on stress has obvious flow abnormality, assuming you've done all your corrections and everything's right here. And then on stress, it resolves a bit, it gets smaller, but there's still this core here. And so the claim from folks who do SPECT imaging is that this shows that there is a ischemia in part of the wall, like you have perhaps ischemia on the endocardial side of the heart wall, but then as you move towards the epicardium, you can have normal myocardium out there. And so that would be the claim, that we have some kind of partial ischemia, but it's not, if there is an infarct, it's a thin one that's probably on the endocardial side. And you see that, as we'll see with MRI, you can make beautiful high resolution maps of infarcts. You inject gadolinium contrast, wait 15 minutes, make a high resolution picture, and you see every infarct perfectly, right? It's beautiful. And oftentimes what you see is a rim on the endocardium that is the infarct, and then the outer part of the myocardium will be relatively normal. And here's a case where this is the mixed inducible ischemia. So they're kind of halfway, you know, between somebody who's got an infarct and not. So here, this is from a paper. I probably have this paper on the files for this lecture. I'll check and make sure it's there. But it was papers like this this is 2004. Remember, we saw the uptake of this technology was between 2000 and 2010, something like that. So this is in 2004. And using many, you know, patients, they came up with data like this, in which, so here's the pretest probability of somebody having a positive X-ray angiogram. Okay, so if you look at this patient, they come in with characteristic symptoms. and say, okay, you got a 50-50 chance you have heart disease, like coronary artery disease. Let's do an EKG. You put them on, they walk on the EKG and stuff like that. And then after that test, you look at it, you go, well, it's not for sure, but from 50-50, we've gone up to about 70% that you've got heart disease. And then they send them to nuclear medicine, right? And averaged over all of these patients, it's not a perfect thing. They say, okay, that increases by another 10% if nuclear medicine is positive. We can tell you that we're going to move up to 85. And so you look at all over the pretest probabilities, and so this becomes the new ROC curve with ECG plus nuclear medicine. And then probably almost as valuable, if this patient's ECG is negative, they still actually have about a 30% probability of having heart disease because of these other symptoms, right? And their ECG just isn't cooperating as a test. They're really good at giving you a positive ECG. But if they have a negative nuclear scan, so that's the first one we started with, everything is perfectly lit up, they don't have flow abnormalities, then that drops their probability down to probably under 10% that they have heart disease. So it's this kind of curve that was used to go to Medicare and say we should do these tests, go to insurance companies and say we should do these tests, because it will, in this case, prevent people from going to the cath lab because you will have dropped their probability down so they stay out of the cath lab. In this case, it will push the right people into the cath lab, right? Now, there's a lot of papers written on this. And but we'll see when we look at the PROMISE trial. I'm not sure, to be perfectly honest, I'm not sure I believe this data. And I think this data is probably biased by the fact it was obtained from people who went to cath and had a positive cath, right? So they were only looking at a partial patient group, then all comers, right? Trials like this in which you show change in probability of somebody's outcome are really dependent on who you let in the door for that trial. And so you really have to be careful on not pre-selecting or post-selecting the patients that you create these statistics with. Okay, so sensitivity and specificity of these tests. I think I probably threw this up before, but as you can see, ECG is not very sensitive. A lot of people with positive disease get through the ECG test without a positive result. Its specificity is pretty good. If you have a negative ECG, you're not bad, but a lot of the positive people get captured in that pool, in this pool. Exercise echo, I'm not sure I believe these numbers, but this is what they're claiming. They have 85%, 80 to 85% in good specificity. And then this is myocardial perfusion scans. You know, dobutamine is stress echo, dobutamine MRI. And so this is myocardial perfusion scans, which is nuclear medicine. And they're claiming here they have a 90 to 91, which seems oddly specific. But anyway, 90% sensitivity and 75% specificity. That I am very doubtful that these numbers still hold up today. But I think these come from studies that were biased by selecting people who had positive cath. But the big one here is like CTA captures virtually everybody. It captures all disease, but unfortunately, the specificity can be down as low as 65%. So it's going to throw people into the pool who are normal as well. Okay, so here's a in-office SPECT scanner, which I'm not saying this is used a lot, but you can buy one of these for a very low price and stick it in the back of your practice and do it on as many people as you want. And back in the day, you could charge $1,200 for it. Okay, we'll start with pet next week.